Imagine spending months on Ozempic or Mounjaro, enduring the nausea, the fatigue, and the weekly injections, only to see the scale barely move. If you feel like a failure, I'm here to tell you, it's not your willpower, it's likely your DNA. Welcome back to Next Gen Pharmacist. I'm Dr. Weam Aldiban. Today, we are solving the non-responder mystery. We are bridging the gap between frustrated patients and busy clinicians by breaking the code on the GLP-1 receptor variants that dictate who lose weight and who just gets the side effects. Whether you are looking for answers for your next appointment or you are a provider ready to move past trial and error dosing, this is your roadmap to the future of metabolic medicine. Before we dive into the genomic data, a quick but important note. The information in this video is for educational and informational purpose only. While I am a Ph.D. pharmacist, I'm not your doctor. Pharmacogenomics is a rapidly evolving field, and you should never start, stop, or change your medication dosage based on this video. Always consult with your prescribing physician or a licensed healthcare provider before making any medical decisions. You might think your pancreas handles insulin all on its own, but it actually takes cues from your gut. Look at this graph. When you take glucose intravenously, your insulin response is that flat, black line, pretty underwhelming. But when you eat the same glucose, the teal line spikes. That massive gap is the incretin effect. More than 50% of your insulin secretion is actually driven by gastrointestinal hormones called GLP-1 and GIP. This surge only happens in response to food passing through the digestive tract, not just sugar in the blood. So, who's sending the signal? Meet the L cells, located in your distal ileum and colon. These cells are the primary recruiters for your metabolic defense team. These cells secrete GLP-1 to communicate with the rest of your body. GLP-1 works by stimulating insulin, increasing your feeling of fullness, and delaying gastric emptying so you don't process sugar too fast. And here's the catch. In type 2 diabetes, this communication line gets cut early. It's not just about blood sugar, it's a feeler of the gut to pancreas signal. In type 2 diabetes, the incretin effect is impaired very early in the progression of the disease. Because the natural effect is weakened, patients often require replacement therapy to mimic these hormones and get the system back on track. To understand the genetics, we must first understand the mechanism. We are dealing with incretin mimetics. Ozempic, semaglutide, this is a selective GLP-1 receptor agonist. It targets the pancreas to manage insulin, the brain to signal fullness, and the stomach to slow digestion. Mounjaro, tirzepatide, this is a twincretin. It hits the GLP-1 receptor and the GIP receptor, GIPR. By targeting both, it adds a third layer of efficacy, acting directly on adipose tissue to improve insulin sensitivity. Think of these drugs as high-precision keys designed to open specific metabolic locks in your body. Ozempic and Wegovy. Semaglutide. This key is a selective GLP-1 receptor agonist. Under FDA guidelines, we use this molecule in two distinct ways. As Ozempic, it's indicated for glycemic control in type 2 diabetes and to reduce cardiovascular risk. As Wegovy, the FDA has cleared it for chronic weight management in adults with a BMI of 30 or greater, or 27 if they have weight-related comorbidities like hypertension. For Mounjaro and Zepbound are both tirzepatide. Following the latest FDA approvals, Mounjaro is our tool for superior HbA1c reduction in diabetes, while Zepbound is indicated for obesity. Remarkably, as of 2026, the FDA has even expanded these indications to include moderate to severe obstructive sleep apnea in patients with obesity. But there's the clinical reality. A key, no matter how well engineered by the manufacturer, is only as good as the lug it binds to. According to the FDA-approved titration schedules, we start low, 0.25 mg for semaglutide or 2.5 mg for tirzepatide, to allow the body to adapt. However, if your genetic luck is shaped differently due to the polymorphisms, the titration doesn't matter. If the key won't turn because of your DNA, the standard dose won't produce the standard result. That is where our journey into the GLP-1R and GIPR genes begins. Let's look at the blueprint that determines if these FDA-approved keys will actually work for you. These aren't just random letters and numbers. These are the structural blueprints of your body. Let's look at the GLP-1R gene, a specific missense variant RS10305420, where the amino acid proline is swapped for leucine. Actually, decreases weight loss and blunts the HbA1c drop. It directly modulates your glycemic response and how fast your stomach empties. Now, check out the ARRB1 variant RS3765467. This is a total game changer. Data from the DOD study revealed that patients with this specific marker experience a massive boost in efficacy, about 2.7 millimole per mole greater reduction in HbA1c. This is also a matter for health equity. This ARRB1 variant is found in 6 to 11% of Hispanic and American Indian populations, but it's significantly lower in white European populations. If we aren't looking at the genetics, we are missing a massive piece of a population health puzzle. We see this globally. In a prospective cohort study of Chinese T2DM patients, those with the RS3765467 GG genotype achieved a 1.7% HbA1c reduction, more than double the reduction of those with the AG or AA genotypes. By combining these markers into a genetic risk score, we can now identify the top 5% of optimal responders before they even take their first dose. But efficacy is only half the battle. Let's look at the other side of the clinical coin, safety. Why do some people suffer from notorious dose-limiting side effects? Brilliant research by Long and colleagues shows that while female patients are generally more susceptible to GI issues, the risk is specifically tied to carrying the T allele of RS2254336 and the A allele of RS3765467. When a patient complains of severe nausea, it's not just low tolerance, it's a genetically driven hypersensitivity. Furthermore, look at RS6923761. If you carry the A allele, your gastric emptying time can jump to over 2 hours, compared to just 60 minutes in others. This polymorphism mechanically explains the physical fullness and prolonged nausea that causes patients to quit therapy. We also have to consider TCF7L2, the diabetes gene, that causes resistance to insulin secretion, and WFS1, where drug like liraglutide might actually act as a rescue therapy for specific cellular defects. I know we have covered a lot of genomic ground today, from the structural changes in the GLP-1R receptor to the population-specific benefits of the ARRB1 variant. To make this actionable for your next clinic day or your next doctor's visit, I've organized everything we have discussed into 2 quick reference tables. First, let's look at efficacy. If you want to know how well the drug will lower HbA1c or drive weight loss, these are primary markers. Notice the ARRB1 poster effect and the TCF7L2 resistance marker. This is how we identify those super responders before the first dose. Now, for the most important part of patients' retention, safety. If a patient is struggling with side effects, it's often a hardwired hypersensitivity. Use this table to adjust your titration schedules. If you see the A allele on Rs69236761, you are looking at a stomach that takes twice as long to empty. That patient needs time, not a higher dose. It's worth to mention that no official CP guidelines. As of 2026, the Clinical Pharmacogenetics Implementation Consortium has not published standardized actionable therapeutic recommendations for semaglutide or tirzepatide based on genotype. And current clinical evidence linking genetic variants like GLP1R or GIPR to GLP1 dual agonist efficacy and safety is primarily classified as level 3, which low quality, or level 4, while research shows significant trends like Rs1035 for 20 impact on weight loss. It's not yet robust enough to support definitive clinical dosing guidelines. So, interpretation by qualified genetics specialists is strongly recommended. The one-size-fits-all era of metabolic medicine is over. We now have the blueprints to predict success and prevent suffering. If you found this clinical summary helpful, you can subscribe to Next Gen Pharmacist for more deep dives into the genomic frontier. I will see you in the next lecture.